to Psychological Explorations with Dr. Michael Axelman and Daniela. We explore an article that was published back in 2006 in the Journal of Infant, Child, and Adolescent Psychotherapy entitled Making Use of Aggression in Child Psychotherapy. In this article, informed by Winnicott's seminal 1969 piece, The Use of an Object and Relating Through Identifications, I aim to illuminate the transformational possibilities that emerge when adults view particular forms of aggression as expressions of hope. I examine the process associated with taking a child from what Winnicott referred to as object relating to object usage, with the particular focus placed on the links between theory and practice. I highlight the importance of one mobilizing the social environment toward the attention of the child through limit setting, while concurrently tolerating the child's aggressive acts by not retaliating or retreating. This shared relational journey involves helping a child move from the omnipotent but very lonely, anxiety-filled, encapsulated world of their own projections to a co-constituted reality, and involves the child engaging in destructive activity, aggression, and the significant adult surviving. It is hope that underpins this destructive enterprise. When the child finally comes to realize that the other is not under their omnipotent control, that is, when the child has tried to destroy and the other has survived, the child can then and only then forge a mutual partnership with the other. Conceptual points are illuminated through the presentation of case material. Object relating, as Winnicott made clear, is a one-sided affair, in which the other is related to as a collection of projections, rather than as a separate person. With the achievement of object usage, the child develops an appreciation of the other as distinct and situated within a shared reality. This acknowledgement provides the blueprint for mutuality, which emerges with the achievement of object usage. The psychotherapeutic sequence that is involved with seeing a child through this stage of object relating to object usage was described by Winnicott as the most irksome of all early failures that come from mending. This thing that there is between relating and use is the subject's placing the object outside of the area of the subject's omnipotent control. That is, and I continue the quote, the subject's perception of the object as external phenomena, not as a projective entity. In fact, recognition of it as an entity in its own right. He continued, this change from relating to usage means that the subject destroys the object. The inclusion of the word use in the title of this article is an acknowledgement of Winnicott's 1969 influential article. However, this terminology is at odds with our everyday understanding of the word, and as such often leads to misunderstandings with respect to the overall concept associated with object usage. For instance, we rarely think in everyday language of the capacity to use people as a developmental achievement. However, Winnicott had very definite ideas about object use. He saw the capacity to acknowledge the other as a separate person and to enter into a shared conception of reality with another as a developmental opportunity. Love, reliance, and the capacity to make reparations are all part of the achievement of object usage. Winnicott, in the summary at the end of his article, noted the following sequence. The subject relates to the object. The object is in the process of being found instead of place by the subject in the world. The subject destroys the object. The object survives destruction. And finally, the subject can use the object. The key elements of this sequence include destructive behavior on the part of the child and survival on the part of the object. As we know from our challenging clinical work in this area, the destructive efforts of children can take many forms. At times, the destruction takes the form of physical and verbal aggression that is directed towards the object. Other times, a war of attrition is waged by the participant through the enactment of a seemingly unyielding set of demands. The latter example, a war of attrition, is explored in the following case. A parent of a 3-year-old came for a consultation. She reported that she experienced a lunchtime meal with her daughter as particularly challenging. The meal started with her asking her daughter if she wanted to eat at the kitchen table or outside on the patio. The daughter said on the patio, and the mother set the table outside and brought the meal for her daughter and herself. Just before they were about to eat, her daughter changed her mind and said, "No, let's eat inside today." This very kind-hearted mother said okay, and then moved the contents of the table back inside to the kitchen. And then just before she was about to sit down, her daughter said that it was too hot in the kitchen, and in fact she really wanted to eat outside. The mother sighed out loud at this point in the telling, and it was obvious that she found the whole event troubling. She went on to say that her daughter changed her mind 3 more times. On each occasion, the mother got up and moved the contents of the table. The mother in this case she wanted to please her daughter and did not really care where they had the meal. In my consultation, the mother was at a loss to understand her daughter's behavior. My work with this caring mother at this point was to help her see her daughter's behavior as a search for the limit. That is, the child was looking for her mother to clarify the boundary between what was possible and what was impossible, her power and her limitations. The demand served to test whether the child is more powerful than the adult. Demandingness in this context functions to answer the critical question on the mind of the child: where do I end and where does the outside world begin? The child presents with demands that the adult experiences as unreasonable and exceptionally burdensome. Although the child who is nested between relating and usage may overtly state that they want this toy or that piece of cake, all the while the child is hoping unconsciously that they find the limit. It is hope that underpins this entire destructive project. The child hopes and wishes for survival. That is, the child hopes that the reality exists outside their omnipotent control. What does survival actually mean in this context? What follows is an articulation of the key components of the relational stance of surviving. I do so through the case of an 8-year-old boy. For the purpose of conceptual clarity, I focus on those aspects of the case that are directly related to the clinical themes of destructiveness and survival. Just after he turned 7, John was referred for individual therapy for aggressive behavior at home and school. The following facts came to light in the previous 18 months. He had a very sad home life. During the first 6 months of the treatment, he lived with his father, who was in the midst of a fragile drug recovery. At this point, Dad was unemployed for over a year and struggling with multiple bouts of depression. The child's mother lived an hour away with her boyfriend. Mother had a felony charge against her for embezzling funds from her previous job. She was also a recovering drug addict with a compromised immune system from years of cocaine and heroin use. About 6 months into the treatment, the mother moved back into the house with Dad and John. The primary reason for this move was that Mother had no other place to live after she ended her relationship with her boyfriend. Mother's mood oscillated from depressed to rageful. During John's fits, she would frequently break down and cry. "Do you see how sad you are making, Mommy?" she would tearfully say to him. John would respond by calling her a crybaby. At other times, she would aggressively lash back at him. For example, when John would throw things at her in a fit of rage, she would throw them back at him. The house at times was chaotic and violent, and foul language punctuated day-to-day family life in the home. Although John lived with his mother and father in the same house, he had lived apart from his mother for 2 long stretches of time, which each lasting over 6 months. The mother harbored intense feelings of guilt about not being available for parenting during these gaps of time and would often indulge him to lessen her own guilt about not being available. John was described by his father as very difficult. Dad described violent fits that John would have at home that involved throwing plates and glasses from the kitchen and punching and kicking him. Dad reported that sometimes his behavior became so aggressive that the only thing he could do was to barricade himself in the master bedroom until John calmed down. John soon found a way to remove the door handles from the doors in the house. Dad described in one parent meeting the way screws and lock hardware littered the floor around the home. Dad presented as a passive and depressed single father. He had little energy throughout the day, and John frequently had to wake him up in the morning to take him to school. John's paternal grandmother, who was in her late 70s, brought him to his appointments and played a very important role in his life by providing dependability. Although reliable, she was overly pliable and all too frequently gave in to John's demands. She would greet me in the lobby with a smile, often saying that she had to bribe him to get him to come to see me today. "I told him we would stop at the toy store after his meeting with you," she would say in a frustrated tone. John would jump up and down with excitement when he heard Grandma telling me this. What was clear to me very early on in the treatment was that John was in charge at home. The 3 significant adults in his life, mother, father, and grandmother, all accommodated themselves to his demands. John played on the guilt that each of his parents experienced with respect to parental failure. Each of these adults knew quite clearly that either his demands were to be met or a violent tantrum was imminent. On an interpersonal level, John was quite likable. He had a great smile and a quick wit. I frequently found myself laughing out loud in our sessions. Along with his endearing qualities, he also presented with a general sense of anxious restlessness. He struggled with regulating his activity level and was prone to use aggressive solutions to solve problems. In addition to his demanding and seemingly unyielding relational style, he also suffered from a discrete phobia with respect to flushing toilets. He would not use the toilet at school because I saw him directly after school. He would often come to session having to use it, as he came to say over time. However, before he started telling me about his needs with words, The following sequence of events would occur. He would pass gas. At times he would giggle, at other times he would ignore it. I would ask him if he had to use the restroom. His response was inevitably no. He would continue to stink up the room and deny that he had to go to the restroom. The phrase stink bomb from my own childhood would probably best describe the offensive he waged through flatulence. He would eventually cross a bodily threshold and admit that he had to use it. We would walk down to the restroom together, and he would ask me to wait for him in the hallway. When John was finished, he would quickly wash his hands and dart out of the room and then instruct me to go in and flush. Could not flush the toilet while he was present. He found the sound of flushing toilets scary and unnerving. The stage of object relating over time becomes fraught with anxiety. Anxiety is one of the byproducts of feeling all powerful but not knowing how to accomplish some basic tasks associated with adulthood. For instance, the child feels omnipotent and all powerful but does not know how to make himself a hot meal in the kitchen. This budding awareness of the discrepancy between omnipotence and competence creates anxiety within the child. I came to view his discrete toilet flushing phobia in part as a marker both to him and to me of the limits of his omnipotence. John and I struggled with all kinds of endings together during this treatment. Flushing the toilet after he moved his bowels was just one of them. Toward the end of his first year of therapy with me, a particular relational pattern became dominant during the last 15 minutes of each session. John would ask if he could take toys, and he would ask to take a toy that he was playing with home with him. Each time he made these requests, I would remind him that the toys needed to stay in the room. It was understood that he could take his writings and drawings, but not his toys that he was playing with. He would, at the height of this phase, scream at me that he needed this toy. These episodes would often culminate with him throwing the toy across the room, sometimes aimed directly at my head. Each time I remained calm, but held firm to the limit. I know that you really want to take this toy home with you today, but you can't. I would say to him in a firm and calm tone, it needs to stay in the room. It will be right here on the shelf waiting for you when you come back next week. It was very difficult for me to be with John during these dramatic tantrums. The episodes often involved him dumping all the toys in the cabinets onto the floor. Puzzles, board games, Lego pieces would be strewn all over the room at the end of these sessions. It was especially difficult for me when he would dart out of the room. Another therapist used this particular playroom in the clinic immediately after our session ended. Only 10 minutes was built in to the schedule for me to tidy the space. If John did not help to clean the room at the end of session, I would spend this 10 minutes of time period organizing the room myself. However, on those days when he'd emptied every single cabinet on the floor and went darting into the hallway, I certainly had my work cut out for me. I had to locate John in the building and escort him to the lobby where Grandma was waiting. After saying goodbye until next week, I'd then quickly head back upstairs to clean the room for the therapist who needed the space at the top of the hour. It was especially frustrating for me on one occasion when the therapist had to wait outside the room for with her client while I finished cleaning the room. I came to dread the end of sessions during this period. Fortunately, the acute stage of this phase eventually ended. He began to accept the limit that was provided. More importantly, he began to experience relief in the face of the limit. Although he would continue to ask to take particular toys home, he began to laugh and smile when I repeated the same phrase to him week in and week out. He no longer experienced an escalation of aggressive behavior in the face of the limit. Destructive activity gave way to calm. It was clear that he had come to accept the limit, and by doing so, he experienced relief. Both the subject and the object, the therapist, learned in a very visceral way that survival brings symptom relief. Thus, as Winnicott described in his 1969 use of the object paper, that this acute phase of treatment was part of John's progression from object relating to object usage. It was notable how the therapeutic alliance deepened as he came to accept reality and the limit. The two key features that were highlighted when I saw John through this phase were tolerance and limit setting. Tolerance was expressed through my low level of reactivity towards John's destructive episodes, and by my consistent patience with respect to his aggressive style of relating. Limit setting brought reality to the forefront of our developing therapeutic alliance. He came to know that when I said no, he had come upon a limit. This was a very different experience than he had at home with his parents and grandparents. His parents never survived. Mother would break down in tears. Father would retreat to the safe haven of his locked master bedroom. Grandma would capitulate and buy John an endless series of toys that he just needed. The power that comes with omnipotence is too scary, and the solitude that accompanies omnipotence is too lonely. It is here that aggression and the destructiveness with respect to finding reality may be viewed as an expression of hope. The hope is that reality exists out there beyond one's omnipotent control. With the real world come people to whom the child can engage in a meaningful way and receive feedback about what Winnicott referred to as other than me substances. Along with presenting reality during these destructive episodes, my effort at limit setting also set the message to him of my ongoing vitality and survival. He was presented with a firm edge off which he could bounce, with which he could come into contact and thus feel real. Survival in this context meant not retaliating nor retreating. Winnicott in 1969 articulated this non-retaliatory stance as, and I quote, "These attacks may be very difficult for the analyst to stand, especially when they're expressed in terms of delusion or through manipulation, which makes the analyst actually do things that are technically bad. I refer to such a thing as being unreliable at moments when reliability is all that matters, as well as survival in terms of keeping alive and of an absence of the quality of retaliation." Thus, our task, according to Winnicott, at these most challenging of all moments in treatment, is to stay alive and not retaliate. That is, we do not retaliate and we do not retreat. Retreat in the face of destructive attacks can happen in quite a subtle way and often goes without notice. It can involve a cognitive shift inward to our thoughts and fantasy, away from the aggressive and destructive contact boundary with the other. That is, we retreat from the destructive relational space of the child to the safer world of ideas or fantasy in our heads. Thus, the therapist may feel compelled to interpret or intellectualize in the face of aggression. Tolerance involves holding one's ground in the relationship and involves making the effort to reduce one's tendency towards reactivity. At times, doing nothing is exceptionally hard to do. All the while that one is employing a tolerant stance, one is also setting clear and firm limits. Limits define the boundaries of a relationship and are part of the full expression of a caring relationship. To set a limit is to delineate a boundary between oneself and another, and thus open up the possibility for a mutual relationship. The therapeutic alliance deepens at the limit. But simultaneously, another pattern may emerge with respect to tolerance and limit setting. For a period of time, tolerance and limit setting may exist in the background, and are remote from the direct treatment process. However, while the therapist is going through a quiet period in treatment, someone else in the child's social system is likely receiving the hate and aggression. This may be the parents or the child's teacher at school. This quiet period could last weeks or many months. However, at a certain time, when the child has developed confidence in the reliability of the setting, they will begin anew to test the limits. During this phase of the treatment, limit setting moves to the foreground, and one's ability to tolerate the destructive activity of the child becomes challenged. In addition to destructive activity in the session, the child may also attempt to modify the frame of the treatment by darting out of the room halfway through the session, or by refusing to leave a session when the time has expired. One could view each of these instances as the child trying to discover the limits to his own omnipotence. With the discovery, there is relief and a deepening of the therapeutic alliance. Again, the therapeutic action associated with the transition from object relating to object usage occurs at the limit. It is at the limit where the child feels real and as they bounce off a relational boundary that holds tolerantly firm. In addition to the adoption of a relational stance towards the child in therapy that includes tolerance and limit setting, this same rubric may be used to guide consultations with parents and teachers who are struggling with a particular child's destructive ways of relating. For example, during the beginning quiet phase of my treatment with John was actively testing the limits with his second grade special education classroom teacher. John attended school in an affluent suburban community. The school staff prided themselves on their unyielding stance of zero tolerance to violence. Zero tolerance for violence has become a catchphrase in many school districts these days. According to these policies, children who engage in violence face disciplinary action that includes suspension and even expulsion. When consulting with John's teacher, I highlighted the importance of the school's zero tolerance policy. I let her know how important firm limits were to John at this point. She agreed and told me about the very clear rules that she had instituted in her classroom. After highlighting what she and the other staff were clearly doing right, I went on to explain to her the importance of tolerance as well. I explained that John was proceeding through a phase with her that she needed to tolerate a certain amount of aggression on his part. I explained that suspension or expulsion would be experienced by John as retaliatory, and that a calm, firm stance would be best. She seemed to understand my communication, and at the end of the school meeting that occurred many months later, she told me how important this feedback was to her. Over the weeks that followed our initial conversation, John's behavior calmed down significantly at school, and he began to settle into a classroom routine that involved learning. The ways in which parents and mental health professionals, especially educators, view acts of aggression by children and youth has recently shifted in the public eye from a force that needs to be expressed, channeled, and integrated to one that needs to be eliminated or at least significantly constrained. This sea change is reflected in all social institutions that cater to youth, and especially in schools where zero tolerance policies for aggressive acts are quickly becoming the norm. It is difficult to understand how children are going to learn how to integrate aggression into healthy living without a social context that tolerates its expression. The need for safe and secure schools is without question an essential prerequisite for learning and development. There are, however, unintended developmental costs to the way that current discipline practices and safe school policies are enacted. Indeed, there is compelling evidence that the well-intentioned efforts on the part of school officials to maintain a safe educational environment are in conflict with the central developmental tasks of progressing from object relating to object usage. From an object relations point of view, these interventions seem so clear, yet they are miles away from how teachers, school administrators, and educational policymakers view and respond to childhood aggression. Although zero tolerance may make great sound bites for politicians and school administrators, it is insensitive to the children's developmental needs. Children learn tolerance when they are treated with tolerance. To summarize, in this article I've aimed to illuminate the progression from object relating to object usage and to delineate for therapists and other significant adults a particular way of relating and engaging with children who are in the phase between object relating and usage. Tolerance and limit setting have been highlighted as two central features of this way of engaging with youth who are in the throes of discovering their limits. This shared relational journey involved in helping a child move from the omnipotent but very lonely, anxiety-filled, encapsulated world of their own projections to a co-constituted reality involves the child engaging in destructive activity, aggression, and the significant adult surviving. It is hope that underpins this destructive enterprise. When the child finally comes to realize that the other is not under their omnipotent control, that is, the child has tried to destroy and the other has survived, the child can then and only then forge a shared partnership with the other. It is through tolerance and limit setting that we usher a child into the potential space of mutuality. Thank you for joining us today. Please come back for future presentations on psychological explorations.